Okay, great. Hi, everyone. My name is Sarah Crowe. I am a nurse practitioner working in critical care at Surrey Memorial Hospital. My partner, Fuchsia Howard, is from the University of Victoria. And the purpose of today is just to give you a little bit of a background on the research that we're doing and to let you know how we came to have patient partners and what that experience has been like for us. I do want to acknowledge and disclose that our research is graciously funded by the Michael Smith Foundation through the BC Nursing Research Initiative Practice Grant Program. Before I get into the actual research, not realizing everybody's backgrounds, I just really wanted to provide a sort of brief grounding in the population that we are researching, which is the chronically critically ill population. So this group of patients comes from a variety of mechanisms. There isn't one definite illness that leads to chronic critical illness, but these patients are generally those who either are in the ICU setting for longer than 28 days or are patients who go on to require long-term ventilation. These often are patients who have complex past medical histories, lots of different issues going on, and for a variety of reasons develop chronic critical illness. In the Fraser Health region, we do have a residential care unit located within Care Life Fleetwood, which is a larger care facility. The unit is called Maple House, and here at Maple House we actually have a dedicated 22-bed unit that is specifically designed to care for individuals who go on to require lifelong mechanical ventilation. So this is living on life support, essentially. And so how I got involved with this group was here at Surrey Memorial Hospital in our critical care ICU and our high acuity unit. It was brought to our attention a couple of years ago that we were seeing an increased usage of acute care services by the residents that lived at Maple House. One of the clinicians started keeping track and brought the data to me and just said, wow, we're seeing these patients come quite frequently. There's a lot of distress felt by these patients and their families, and we're wondering about the impact on their quality of life, and is there anything that could be done? And so that really spurred my involvement in the unit, and we started to take a closer look at exactly what was going on, trying to figure out if there's anything that we could do as a healthcare team to hopefully impact and improve their experience and also their quality of life. So as we began looking into the reasons, we actually found quite quickly that it was a very complex issue and that we were going to need a whole team to support us in developing and looking into these issues. So we brought together clinicians, administrators, and researchers with the whole goal and purpose of trying to improve the experience in healthcare of these chronically critically ventilated patients. To begin, our team had a physician champion, which is Dr. Greg Helgen. We had nursing clinical leaders, myself, and then also nursing leaders from Care Life Fleetwoods. We had operational leaders, including the care coordinator, the manager, and the director of the facility. And we also brought in interdisciplinary partners, social workers, respiratory therapists, spiritual advisors, really trying to get a better understanding of what was going on. In the beginning, we started with a retrospective review. We wanted to really look back at the previous couple of years to see what was bringing these residents back to acute care, to see if there was something that we could do to impact. So when we looked back, we were able to discover that there was sepsis or infection seemed to be the driver in this. So we really started to dig deep into that and to see if there was a way that we could actually intervene earlier. Throughout this process, as we were looking into the reasons, we developed better relationships between the acute care and the residential care, and we were able to understand one another's experiences as well as the experience and the needs of the residents. Early on, we brought in Dr. Fuchsia Howard from UBC, who was a nurse leading research in the domain of cancer survivorship, and we were able to use her body of research in cancer survivorship and apply some of the concepts to ICU survivorship, and that began our research partnership. So using the initial findings of the retrospective review, so we looked back at all the admissions either to the emergency room or for those who got admitted to hospital in the 2 years leading up to our current research. We were able to find out that sepsis, whether it was from pneumonia, urinary tract infections, or bloodstream sepsis, seemed to be the driving features of why patients were coming back to acute care. In partnership, we were able to develop and implement an early screening tool that was effective for helping staff recognize earlier in the infection process that there was something going on so that we could implement treatment faster. We were quite successful in reducing emergency room transfer or visits and acute care admissions. We were able to decrease transfers by about 30% to hospital with this tool, and we also decreased the length of stay by about 20% of those residents that did go on to get admitted to hospital. So it was quite effective. We soon realized, though, despite all this, that we still were not understanding the experience of the residents, their families, or even the staff that were caring for them. And so that helped to spark our latest project. So we really wanted to understand the experiences and the sources of distress for this group of patients. And so our question, what are the healthcare expectations and sources of distress for the chronically critically ill ventilated residents, their families, and staff that care for them, was developed. We developed some strategic goals early on. We really wanted, our overall arching goal was to improve the experience of everyone involved, particularly the patients and families, but also the healthcare providers that were caring for them. We also wanted, as a secondary goal, we wanted to optimize the collaboration between acute care and community resource. We wanted to improve access to specialists and specialty care for these residents. And we really wanted to develop a knowledge to action plan. So we didn't want to just understand what was going on. We really wanted to be able to make improvements that were worthwhile and that meant something to the people on the ground. We really wanted to have a shared sense of ownership and a responsibility for our work. We really wanted to make sure that whatever we recommended as a result of our research could actually be implemented and was actually useful. So early on, we realized, as we were reviewing some of the literature, we were seeing a lot of themes throughout the literature, and we were seeing some common recommendations. And knowing this and seeing some of the recommendations, we really started to think about, were we actually asking the right questions? If we're still at the same place of needing to understand this better, were the right questions being asked of the participants? And that started us thinking about, once we had the right questions, how would we know that we were analyzing the data properly? And then once that was done, the recommendations, did they make sense and were they applicable? And so very quickly and early on, we realized that having a patient partner was going to be essential to making our research successful. We didn't want to create scientific knowledge for the sake of creating knowledge. We really wanted to make something that was going to be useful and meaningful to the patients that we were trying to serve. So very early on, we connected with the BC Support Unit and also the Patient Voices Network. We were looking to engage patients to be part of our team. This was a really new idea for us. We had started to hear about patient engagement from other groups, and I'd seen a couple of presentations through the Patient Voices Network. So we reached out to the BC Support Unit to see what they could do to help us. And they were wonderful in supporting us in trying to draft up, advertisements so we could start to advertise to recruit patients. We began our process very narrow. We were very intent upon finding the right patient partner, and we were really hoping to recruit somebody who kind of fit the same or very similar circumstances what we were looking to research, so the chronically critically ill. We did advertise for quite some time looking. We found that we didn't get a lot of response, and that we thought, okay, so maybe we were too narrow. So we were really looking for either somebody who was currently living with chronic critical illness or family members who had cared for somebody. And so after we had the advertisement up for about 4 to 6 weeks, and we didn't get much of a response. So with support of the BC Support and the Patient Voices Network, they encouraged us to broaden our search. So we, in a stepwise approach, we slowly broadened our search. We still wanted to try and keep our patient partners having experience as close to what we were looking at as possible, but realizing that it was such a very specific small niche that we had to be broader. Unfortunately, we weren't all that successful initially in recruitment, and actually it ended up being word of mouth that I was able to find our wonderful patient partners. A colleague of mine who works with the older adult network within Fraser Health had mentioned a wonderful patient partner that they had found and how engaged she was, and just the fantastic ideas and strategies and input she had. And when I was listening to her talk about it, I just thought, wow, this sounds like somebody that I need to meet. So I asked my colleague if she could introduce me to her patient partner. My colleague reached out to Adrienne and let her know a little bit about my project and what I was hoping, and asked if it'd be okay. Adrienne was very excited to be asked, and so was open to the connection, and so began our journey with our team in connecting with patient partners. The initial conversation with Adrienne was done through email. I did ask at that time if she had anybody else within her own network that she thought might be interested, and she right away encouraged us to consider her colleague Joan. So to begin with, we met with Adrienne and Joan, just Fuchsia and I, just to describe sort of what we were thinking, the background of our research, what we were hoping to accomplish. We really wanted to kind of just lay it all out in a really informal way, just to explain and be able to answer any questions about what we were thinking or why we wanted to have patient partners. And it gave Adrienne and Joan an opportunity to meet Fuchsia and I as the main contacts and to ask their questions. We encouraged them that really we were hoping to have them engaged with the entire process of the research project, but that we were open to sort of as much or as little as they desired, and that what was important to us was to make sure that they found it meaningful, because we were really looking to them to help guide our research. So after explaining sort of our vision for the research, I'm happy to share that Adrienne and Joan were very excited to be a part of our team. We're very engaged in the process, and we're excited to be involved in a formal research project. Adrienne and Joan both have similar backgrounds. Adrienne had cared for her husband through his Alzheimer's disease before it took him, and Joan is currently caring for her spouse who is struggling with Alzheimer's. So they know what it's like to be caregivers and family members of people who are struggling with complex needs and issues and having to interact with the healthcare system. The input they have brought has been so valuable. I can't say enough good things about just the perspective they bring and the richness that they have brought to our team. They have such a unique way of looking at the data, looking at the questions that we're asking, and to say, you know, had you thought about this question, or this might be really interesting. So it's been so wonderful, and they've been so engaged with the process that we're definitely happy to say that having patient partners has made our research team richer. So what was very important for us as a team as we looked at engaging our patient partners was the three themes of being inclusive, providing connection and appreciation, and overarching, of course, is respecting their time and involvement. The research project, when we first engaged Adrienne and Joan, although we'd started designing it as we were trying to recruit our partners, once we had our two partners engaged, everything was shared with them. We met face-to-face to describe our vision and their desire for the research. This gave them an opportunity to seek the clarification and ask questions. It also gave them an opportunity for them to share with us their initial thoughts about A, the research, and B, what they wanted the role to be. It also provided them an opportunity to see how they might like to be included. Connection has been an ongoing important aspect of our team. We try to meet regularly every 1 to 2 months as the project has been progressing. We provide regular email updates between the meetings. And then to ensure that we engage our partners, we make sure that we send out materials ahead of time, either by email or mail. As we've been going through transcripts now, trying to make it as easy for our partners as possible, I've been mailing out copies of the transcripts for them to review. Each meeting, when we do meet face-to-face, meets with a check-in where every member is able to kind of share where they're at, how they're working through the information that's been provided. Kind of gives a summary of the research process to date, and then we provide sort of a summary or the vision of our meeting, and then have an opportunity to ask questions or seek clarification. The meetings are generally kept for about 1 to 2 hours. We really want to respect their time and volunteerism. Part of our goal, too, is to keep our jargon at a minimum and definitely creating an environment of permission to interrupt and to seek clarifications along the way. And then the final piece, which has been really important for us as a team, is appreciation. So as a part of our research grant from the Michael Smith Foundation, we do have funds, so we help reimburse their travel expenses and have been able to offer honorariums just to appreciate the time commitment they've provided. We have started to do a few different presentations, and there's been a few manuscripts that we've started working on, and our partners are included as authors in all presentations. They are also given the opportunity to co-present. They weren't able to today, but we have had Adrienne co-present with me at the Fraser Health Research Week in the past, and we'll continue this going forward, is to make sure that they're connected and offered every opportunity as an equal member of our team. So where we're at in our journey right now is I'm happy to report that we've completed all the data collection, so all the interviews. We have interviewed family members, residents, and then we've also added staff to the data. We're in the process. We've had all these interviews transcribed, so the whole team is slowly working through reading all the transcripts. As we're reading through the transcripts, we're making reflections and keeping notes about our experiences and how the stories are impacting us, so that we can use that information to help guide the analysis and the recommendations. We have 2 different research assistants that are helping us. One was helping us with the interviews, and they were able to come and help share their experience with the whole team as well. And now we've engaged another assistant to help with the coding of the data. We are hoping to wrap up our analysis in the next 2 to 3 months, and are hoping to start working on our recommendations from the research. Our patient partners are valuable at every step, like I've said previously, but especially as we're working now towards the analysis. Their view on the transcripts has been so important, especially from their perspective as family caregivers. They've really opened our eyes when we've been looking at data and saying, well, I think this means this. They've been able to ask questions and go, well, actually, have you thought about it in this way? Or as a family member, this is what I think they're actually mean or what they're saying. So already our research project is so much richer from having their input. They've been very good about picking up on subtle nuances or clarifying the meanings of words or what they view the words meaning, as we often get sort of lost down a path of the medical terminology or our medical experiences. They've been very good about bringing us back to the here and now experience of the family members, and already they've really just opened our eyes to what that experience is like. So next steps is to develop the recommendations and to develop an action plan on our findings. So our hope is, first we're going to engage the immediate research team, which includes our patient partners, to come up with what we think recommendations or actions can be. And then we're going to open it up to the larger leadership team, which will include, the clinical leaders, medical leaders that are involved in the care of these residents, the family members. Our hope really is to share this to make sure that it makes an impact, not only for the residents and families that we're caring for right now, but also for the future families. Our hope is to be able to continue to build on this research. We've already started looking at potential next projects. Our patient partners have identified areas that they believe we can take different avenues, and they've also begun to brainstorm different areas that they think that we can be sharing with the community. So their involvement is going to be just vital in trying to expand this research, make sure the research findings are meaningful, and that we talk to the right people. Sorry, I was a little nervous, so I think I blasted through a little faster than I anticipated, but I am happy to answer any questions or if anyone has any comments.
Awesome. So thank you, Sarah. That was great.
Sorry about that.
No, that's good. We have lots of time for questions now, so if anyone has some, please feel free. The best way to ask questions is if you look at your name on the right-hand side of the screen. If you click on the unmute button, the little microphone icon, you can ask your question freely, or you can do it in the questions somebody already has. So we have a question from Peter saying, please describe what kinds of stress you are exploring in the interviews and what surveys did you use?
Sorry, can you repeat that again?
Please describe what kind of stress you are exploring in the interviews and which surveys you used. So in the interviews and the surveys.
So what kind of distress, was that the first?
Yes.
So very interesting. We had some preconceived ideas of what we thought the distress was going to be. We, as researchers and as medical personnel, thought that the distress that we were going to see was going to be surrounding the diagnoses or what it was like to live on a ventilator. But a lot of the distress that we've started to uncover is actually around sort of day-to-day choices. There's a lot of distress in worrying, residents worrying about their family members, the family members worrying about the residents, the ability to communicate and socialize, as a lot of these residents are living on ventilators. And the distress of the constant journey back and forth. I don't think as a medical team we appreciated enough just how stressful the actual physical transport was for these patients. And then in terms of surveys, we did use a quality of life survey and a patient family satisfaction survey to evaluate, and I'm happy to share those through to Justin to share to the bigger group if that's possible, Justin.
We can put it up on our website for sure with the webinar, and I think we can send it out to people who have registered with their email address on this.
Okay, or you can email me directly, and I can send those as well.
Perfect. Yeah, that sounds good. And Sarah, if you're interested in providing your email, that would be, if you want to do it that way, that works too.
Sure.
But yeah, great question. And so if anyone else wants to ask a question, you can unmute yourself on the right-hand side, or you can raise your hand and we can do it that way. We have one here from Rita.
Yeah, so, it's Rita Weeb in Prince George. And my question is, do you address the MAID program at all with any of this group of people just for the sake of increasing people's options?
We don't. It has been brought up in one of our interviews as a passing comment, but we really tried to redirect that particular participant to talk to their social worker or physician. But no, we did not address or bring that up.
Okay, I did find that as a parent of my 38-year-old son, that was a very important thing that he wanted to talk about, and nobody was really too willing to talk to him about it. So I had to do a lot of research.
Yeah, and absolutely. The one participant who did bring it up, I mean, we touched briefly on it, and I appreciate that it is a hard thing to get people to talk about, but we didn't instigate that into the conversation. It wasn't a question we asked, but we did talk about it with one participant when she brought it up.
Thank you.
Justin, this is Pat. Can I go?
Sure, go ahead.
Thanks very much, Sarah, for an excellent presentation. I found it super informative. My name is Pat Atherton. I'm responsible for training with the BC Support Unit. So it's lovely to meet you virtually. The question I had for you is around the patient partners that you've engaged in the manuscript preparation, so writing the articles and participating as presenters at conferences. How have you prepared your patient partners to do those pieces of work that they would not have done as regular garden variety human beings?
So looking at writing, we've been sharing outline. We're not actually asking them to do the physical writing, but we're getting their input and getting them to review the written articles, and then they're bringing to our attention ideas that they think we've missed or lost, and then we're able to incorporate that feedback, and then we're constantly sort of feeding it back to them to get their approval and get their input. For the presentation, we co-developed a presentation. We talked about sort of what the questions might be that people might ask. Adrienne sort of practiced with me, so it wasn't really a formal preparation. It was very much more informal, and then it was just encouraging her that it wasn't an expectation of ours, but we would love for her to share that with us, and if she felt comfortable, which she did in that particular venue, that she was willing to get up and speak with us. But she definitely wanted the team with her, so that we went up as a united front, so that she would have our physical presence as support as well.
Great. So supporting patient partners is very important then.
Absolutely. I honestly feel like I'm saying the same thing, but I just can't express enough how valuable their input has been, and just how wonderful the research experience has been for our whole team having them as a part of it. There's things they've brought to light that we never even considered, and they just have such a unique way of looking at situations that have really just enriched the whole process.
That's really great to hear. Thanks, Sarah.
No problem.
Thanks, Sarah. We have a question from Prita that is, will the data be available in public, or will it be input in the RAI?
I'm sorry, I'm not sure I'm following the question. The data from our research will be published publicly, and our hope is to have it published in a variety of ways, not just manuscripts. We want to also make it available to the general community. So we haven't quite, we're not finished analyzing, so we don't quite know what that's going to look like, but we've thrown around ideas about whether it was advertisements, patient pamphlets, or family information. We really want it to be not just the scientific community, but also for the general public, because that's who we're trying to improve the experience for. I'm not sure about the piece of the comment about the RAI. I'm not familiar with that.
No, me neither. So maybe if Prita, if you want to elaborate on the RAI, please feel free. We have another question. We have one from Peter, just asking to elaborate more on investigating stress in healthcare providers at both the hospital and chronic care facilities, particularly around moral distress. So, Peter, if you want to elaborate on that, feel free to unmute your mic and provide some more context. But Sarah, if you could, just looking at kind of investigating stress in healthcare providers at hospitals and chronic care facilities, particularly looking at moral distress.
Yeah, no, I think that's a great question, and I think this is actually one of the things that surprised us, because as healthcare providers, we had a lot of assumptions that this distress was, or the moral distress was going to be around providing care to residents who had life-limiting illnesses. And similarly, we thought the residents and the family were going to be more distressed over their diagnosis and living on the ventilator. And so for the staff part of things, I think there is that moral distress of providing care that they may see as being uncomfortable or invasive to patients who have illnesses that are life-limiting. But really hearing the family and the patient perspective and what gives them joy and what gives them quality of life, we've actually explored more what those aspects in our attempt to understand the stress they experience. And so we've heard, from numerous families and patients that they still experience a tremendous quality of life, that the simple pleasure of going outside, of making choices in their day-to-day life gives them joy. And so if we can support those things, they feel less distress. And I think being able to share that back to healthcare providers, I think we get very medically focused on the diagnosis and the projection of the illness that we sometimes forget that there's still joy in life, and that these people are still very much engaged with their loved ones, with their families. They still enjoy the simple pleasures of going outside. We had one resident tell us that every couple of months his family is able to take him out to the beach, and he really enjoys being at the beach and smelling the salty air and hearing the waves, and that couple of hours there just means the world to him, and he looks forward to it. So if we can really try and focus in on those things, I think we may be able to actually help alleviate caregiver moral distress if we're able to get the caregivers to see the joy and fulfillment that these patients still have, rather than us focusing on their terminal illness. I hope that answers your question, Peter.
It answered the question for me. So I thought that was really good. Thank you. We have another question here from Prita, just wondering, was there a difference in patient-resident responses to the study or questionnaires in terms of their length of stay? So was there a difference between the responses from new residents and residents who had been in the facilities for a long time?
Actually, that's a great question, and we actually did have a difference. So we found patients who had been there under a year definitely had a different perspective and a different outlook than patients who had been there. We had a couple who had been there for quite 5 years or longer. Similar themes, but sort of where they were at in their journey was much different. We did hear sort of the ups and downs of the first couple of years of dealing with living on a ventilator, and what that journey, sort of that grieving process and changing to their new reality was quite a challenge to some, and the fulfillment now that they're sort of 4 or 5 years into this now, that they're able to see joy again. So definitely we've been able to see differencing of opinions. And then family members too, the whole transition initially to residential care with the ventilator has been quite challenging, but as they move beyond those first few months, few years, when they figure out the communication, because that's a big thing, just that ability to communicate, it seems to make a big difference.
Awesome. Thank you, Sarah. Are there any other questions? Feel free to unmute your mic or put up your hand or ask the question in the comment box at the bottom of the screen.
And I'm just writing in my email into the comment box, so if anybody does want to email me questions or would like copies of the surveys or anything, please feel free to email me directly.
Perfect. I guess, Sarah, I have one question for you just about the patient partner experience. Were there any lessons that you learned in this kind of process that you see yourself using on future projects that you work on, or anything that you think you'll take into your future work?
from my personal experience as a nurse, being involved in some multidisciplinary projects, or I was very aware of the sense of tokenism, and really wanting to make sure that my patient partners knew that they weren't there so that we could check a box, or to say that we had a patient partner, that they were there as valuable contributors. So I don't know that I would do anything differently. I've been so pleased with how we've been engaged so far, but that was really sort of the underlying sense that when Fuchsia Howard and I first talked about engaging patient partners, that we were very deliberate in that we wanted to encourage their involvement at all levels based on what they felt they were able to or wanted to engage in. We really didn't want anyone to feel a sense of tokenism, that they really are truly equal partners. So I'm not sure that I would do anything differently. The recruitment process was difficult, and so I would probably not have started as narrow of a focus next time, just because it took us longer to recruit than we had hoped. So I would just caution anyone who's engaging in patient partners that, well, you want to be very specific in making sure you have a partner with relative experience that fits your project. You don't want to make it so narrow that you can't find somebody to partner with you, because even though our two partners don't have experience with chronic critical illness, they do have experience as caregivers of somebody with chronic illness, and their perspectives, like I said, has just been so valuable.
Awesome. Well, if there are no more questions, we will let that be kind of the conclusion of the webinar for today. Thank you to everyone for coming. Thank you again to Sarah for the presentation. Once again, a webinar recording will be available on our website in the near future, so feel free to check that out or share that with any colleagues that might be interested. You can learn more about that at our website, bcsupportunit.ca. And for anyone looking to connect with Sarah, her contact information is in the comment box at the bottom of this screen. Okay.
And I just want to thank you guys for having us. We were very pleased to share our process and our project with you.
Awesome. Thanks. Have a good afternoon, everyone.